So our rationale for doing this trial was that currently patients with symptomatic melanoma brain metastasis have really poor outcomes despite all the advances in immunotherapy and targeted therapy in patients with advanced melanoma. So for example, with Ipi/Nivo immunotherapy that we use so much, patients with symptomatic melanoma brain mets, their response rates are around 20% or less. Median progression-free survival is just over 1 month. And we think that oftentimes patients with symptomatic mets, which means have their neurologic symptoms or require steroids, because of those factors, have poor outcomes with immunotherapy despite getting surgery or radiation as part of their management. So our goal here was to see if we could improve outcomes for those patients. So in our study, we had a triplet regimen of BRAF/MEK inhibitor, Encorafenib, Binimetinib with Nivolumab. And patients who were enrolled were randomized to either the triplet arm versus the Ipi/Nivo combination. And so to be eligible, their melanoma had to have a BRAF mutation, and they had to be treatment naive in the metastatic melanoma setting, although they could have had prior adjuvant or neoadjuvant treatment. We enrolled about 30 patients, randomized across the 2 arms. I would say close to half the patients had steroids, were on steroids up to 8 milligrams of dexamethasone at time of enrollment, and about half had already needed prior surgery or radiation for their melanoma brain metastasis. And to be eligible for enrollment, they had to have at least 1 brain met that was progressing after those treatments. With our results, we found that our primary endpoint was overall progression-free survival, so both intra and extracranial, and that the patients randomized to the triplet regimen had an improved 6-month progression-free survival rate of about 54% with the triplet versus about 20% with Ipi/Nivo. Looking specifically at intracranial progression-free survival, our median PFS was 8.7 months with the triplet and Binimetinib arm versus only about 1.5 months with the Ipi/Nivo arm. And with response rates, we also found a much higher response rate with the triplet regimen, about 75% with Binimetinib versus only about 13% with patients on Ipi/Nivo arm. I think our results suggest that, there could be a triplet regimen may be therapeutically useful in patients with symptomatic melanoma brain mets. Obviously, this requires that their melanoma have a BRAF mutation, and that these patients are often treated in the context of a multidisciplinary setting, neurosurgeons, radiation oncologists, medical oncologists, but there may be a role to consider a combination of targeted therapy and immunotherapy for them. Ideally, though, as this is a small randomized phase 2 trial, we would want to validate this in a larger clinical trial and also see how a triplet may compare, for example, to a sequential targeted immunotherapy approach.